My name is Nick Sterling. I'm going to be talking today about concepts and controversies in patellofemoral pain syndrome. Disclaimer, this is not medical advice, so always consult your physician before starting any kind of treatment program or therapy program. We're going to begin with a case scenario of a 24-year-old female who's been referred for anterior knee pain. She's had this pain for about 5 months after she increased her running distance to train for a marathon. And she says it is located mostly over the lateral and superior aspect of the patella. She states that it's worse going downstairs, also worse pain after prolonged sitting. She also states that she has associated snapping and tenderness and pain over the lateral part of the knee, and she points to where the lateral femur epicondyle is. She says, or rather on physical examination, her leg lengths are equal. She's got good strength and range of motion and sensation on examination of the knee and the hip and the ankle. She has a slight effusion of the left knee. There's no visible quadriceps atrophy. There's no instability. There's decreased excursion in the medial direction on excursion of the patella. She does have some tenderness on the lateral undersurface of the patella and some interesting physical exam signs. So she has a positive Ober test. She has a positive Noble test. And she also has pain on resisted extension of the knee associated with crepitus. She also has pain and crepitus on the eccentric step test. And this is her doing the eccentric step test or the step down test. You can see that her weight-bearing leg, the painful symptomatic one, which is the left leg, is rotated slightly inward with apparent collapse or valgus of the knee. She's also got dipping of the contralateral side of the waist. So a little bit of dip over there on the right side. You can see the level of her waistband. So our differential diagnosis at this moment is patellofemoral pain syndrome, which is most likely, and it's probable that she also has IT band syndrome, and these two can go together. And so that's the diagnosis for this patient at this moment. So patellofemoral pain syndrome is relatively common, especially in this type of demographic. So a runner, female, relatively young patients can get this. It's frequently called various different things, which are relatively unhelpful because they don't help us to localize where the pain is coming from. So patellofemoral syndrome, anterior knee pain, which is nonspecific, runner's knee, and chondromalacia patella is a favorite one that people do tend to call this. But the reason why it's not that helpful is because even if there is chondromalacia, the pain is unlikely to be coming from the cartilage. And the reason why is that there's no free nerve fibers or pain fibers within the cartilage itself. So if anything, it's coming from the subchondral bone or other structures, for example, the infrapatellar fat pad or the retinaculum, or potentially ligamentous structures, a little bit less likely, and also synovium, again, a little bit less likely. There may be some neurogenic component to this condition. It's been shown that in various parts of the knee, patients with patellofemoral pain syndrome do have increased numbers of substance P containing nerve fibers, which are essentially pain sensing fibers. There's also demyelination and fibrosis of the nerves that has been shown in the lateral retinaculum, and of course that may be associated with pain. Currently, there are two models that are used to explain the etiology of patellofemoral pain syndrome, which are the tissue homeostasis model and the structure function model. We'll go over each one of these. The tissue homeostasis model posits that there's this envelope of function within which you need to remain in order to have a happy and healthy knee. And that's seen down in the left-hand corner. That thick line there is the envelope of function, and it's essentially the product of the load under which the knee is undergoing extension and the frequency of which the knee will extend under that load. So in order to have a symptom-free knee, you need to remain within that zone of homeostasis underneath that thick line. And then when you go outside of that thick line, that's when you start to have symptoms and dysregulation of tissue homeostasis. There is some evidence to support this type of process within the knee. For example, there's increased water signal fraction on MRI, suggesting that there may be some kind of patellar hypertension syndrome, although this is definitely a theory that is emerging. Some of the newer surgeries targeting this patellar hypertension syndrome for decompression actually have shown pretty good results, and it's not clear whether this is a result of sham effect or not. but important to mention nonetheless, still very much an emerging theory. There's a lot more evidence currently to support the structural, functional view of patellofemoral pain syndrome. You can think of the knee as the kid in the back seat of the car who's stuck in the middle between two of his brothers, potentially, who are elbowing him, and he's getting irritated, and because the knee and rather the hip and the ankle on either one of his sides are misbehaving, then this kid, who is the knee, will also act out and misbehave. And that's essentially how you can view the relationship between the knee and then the hip and the ankle. So we'll start with knee biomechanics. We know that patients with patellofemoral pain syndrome have increased compression forces of the patellofemoral joint. We also know that they have decreased contact area over which to spread those forces. We also see that subgroups of patients, some patients will have lateral displacement of the patella, quadriceps firing, or knee extension, and this does not have to be present to make a diagnosis. This is something that some patients have. Classically, this is thought to be due to weakness and or delayed firing of the vastus medialis oblique fibers. However, once again, this is a subgroup of patients who have this. More commonly, they'll have generalized quadriceps weakness. There is some evidence to support this idea that VMO, delayed firing, or weakness will cause patellofemoral pain syndrome. For example, if you take fresh cadaver specimens and then do a VMO block via a nerve block, and then you stimulate the rest of the quadriceps, this does cause lateral deviation and lateral tilt of the patella with increased compression forces. On the other hand, though, in kind of suggesting more of an associative relationship here, if you inject the infrapatellar fat pad with saline to cause pain, you do end up with decreased, rather delayed firing of the vastus medialis oblique. So it's unclear because of those studies. It's still unclear whether this is a cause or effect of the condition. Since we are talking about patellofemoral pain syndrome, we have to talk about Q angle. So this is actually falling out of favor at the moment, but we'll go over this quickly. You take the ASIS, draw a line to the patella, and then draw a line to the tibiotubercle. And then you take that line that was from the ASIS to the patella, extend it out, you get an angle, and that's the one at the bottom there, and that's the Q angle. So it's usually about 15 degrees plus or minus 4. And this is wider typically in females, and it was thought at one point that this would represent the quadriceps line of firing, or rather the forces with which the quadriceps apply forces to the patella. It turns out that that's not so true. It's also not the case that the Q angle is very predictive of the propensity to develop patellofemoral pain syndrome. And again, there's no correlation, or little correlation, I should say, with symptoms. So at the moment, Q angle is kind of falling out of favor. It turns out that the hip may be more important, in fact, in terms of rehab potential than the knee. This is very interesting because when you do isolated hip rehabilitation exercises, you compare them to people who have done isolated knee rehab exercises, the people who did hip exercises actually tended to do better. Now, it's recommended that for therapy, people would do both combination hip and knee exercises, but still, kind of to emphasize this point, there's a lot of interplay between the hip and the foot and the knee. So, how can these relate to the knee? Basically, we know that patellofemoral patients, they will have increased or excessive internal rotation of the femur across a variety of tasks like walking, stepping, running, landing from a jump. And there are a couple things that can cause that. The first, of course, would be excessive foot pronation, or pronation at the subtalar joint. Another one would be proximal musculature, like the hip, so weak external rotators. You can see from the diagram, the finite element analysis down below, what happens when you have increased internal rotation of the femur. You do get increased compressive forces on the patella. In terms of your hip rehab, you would want to focus, typically you think about focusing on hip extension, hip abduction, and hip external rotation. Those are classically the things that are kind of emphasized in addition to a general hip strengthening program. It's important to be well-rounded. Now, there may be some role of the IT band. In addition, this is just another part of the proximal musculature. It turns out that the IT band actually does insert or communicate with the patella, kind of in the superolateral aspect of the patella via the iliopatellar band. And it also turns out that when you tighten up the IT band, you can cause lateral displacement of the patella. So treatment of patellofemoral pain. This is a publication resulting from a 2016 consensus statement by 8 of the 10 most published authors on the topic. They got together and came up with these guidelines stating that exercise therapy is recommended to reduce pain in the short, medium, and long term, meaning 12 months or more, and improve function in the medium and long term. They recommended combining hip and knee exercises. Of course, I placed these 3 bullets down below. They were not part of the original article, but just to kind of remind us what we're thinking about when we think about hip and knee rehab in this condition. So hip extensors, external rotators, and abductors tend to be weak. Good focus for exercise in addition to a well-rounded hip strengthening program. Also knee extensors to strengthen the quadriceps, and gait retraining you can do for people like athletes who need high function or who have obvious gait impairment. You can do foot orthotics to reduce pain in the short term. We talked about over pronation of the foot. They do not actually recommend necessarily patellofemoral mobilizations. The literature has been relatively controversial on topics such as taping and mobilizations. Typically, the way it's kind of shaking out right now anyway, is that they're not all that effective. But we'll see where things go down the road as various different techniques come out and things tend to evolve. But this is where things stand right now, is that they're not recommended. They also don't necessarily recommend electrophysiological agents such as muscle stimulation at this particular moment. This is just a diagram from a meta-analysis showing that really this is a stubborn problem, and you need to be committed to exercise, or the patient needs to be committed to exercise and rehabilitation of the knee in order to really get the most improvement possible. So the short term here and the medium term are less than 6 months, and then long term is 12 or more months. And you can see that your greatest gains tend to come out in the long term. So really sticking to a good exercise program is crucial. There are surgeries for this condition. They would need to be directed towards an anatomical, identifiable anatomical cause of why you have patellofemoral pain syndrome. Typically, one would be that you have a tight lateral retinaculum, and that this needs to be lengthened up because it's just too much for physical therapy to overcome. But you would try exercise therapy first, typically, and then if all else fails, then you would move to surgery. The risk that you run with doing a lateral retinacular release is that you have medial subluxation of the patella, and then you may have to go in and do a repair, which is obviously not so great. People do arthroscopic debridement. If you have a large cartilage flap, this is possible, but typically it does not make too much of a difference in terms of outcomes. And that's also the case with the lateral release, unless there's some kind of very identifiable anatomic problem, or unless there's severely refractory pain that's extremely difficult to treat 6 or 12 months out from initiation of treatment. There are new interesting approaches. One, for example, is Botox injection into the vastus lateralis, and this can cause a restoration of the balance of strength and timing between the vastus lateralis and medialis, so that they're kind of more in sync together. And that's something that may be emerging, and we'll potentially be seeing more of in the near future. And so that's my talk. Again, patellofemoral pain syndrome. It is a stubborn condition. There is the tissue homeostasis theory, which is important to keep in mind in terms of balance between rest and activity. And then there's the structure function model in terms of how do you think about rehabbing this condition. Surgery for rare cases. You would want to try exercise therapy for a while unless there was a clear anatomic indication for this. And that is the summary of my talk. Thanks for listening, and these are my references.